Assalamualaikum warahmatullahi wabarakatuh. Alhamdulillahirrabbilalamin. Assalatu wassalamu ala asrofil anbiya wal mursalin Sayyidina wa maulana Muhammadin wa ala alihi wa sahbihi ajma'in. Amma ba'd. Well, hello everyone. I hope you're always healthy and keep your spirits up today. Although the weather in Yogyakarta is not really shiny, but it's okay. Well, our event will be touring in online and offline. It's mean hybrid, and also we are available on YouTube right now. It's meant live on YouTube, right? And here are the rules for the participants on the online server. Number 1, turn off your microphone. Second, turn on your video call. Third, don't do anything disrespectful during the events. And here's the rundown of our events today. The first, opening ceremony. Second, speech by Miss Sulistiawati PhD as representative of Ahmad Dahlan University, postgraduate. Third, the event was guided by the moderator. Next, material presentations. Next, discussions, question and answer. Closing and awarding certificates. And for the last, we're gonna do photo sessions. And let's start our activities today by reading Bismillah. Bismillahirrahmanirrahim. And yes, everyone, welcome to the global health issue and strengthening national capacity of achieve equality. Please give applause. Yeah, I think there's so much people here. I think it's about around 10,000 people here. Yeah, it's good. And I would like to thank you so much for everyone that come in here and join up with our meeting. It's been Zoom meeting today and also on live on YouTube, right? With me, Yogyakarta Sanjung, as a public health master public health student at Ahmad Dahlan University, and I will be your host today. Right, for your information, guys, in this advanced era, the global health issue was become an important thing to pay attention and to discuss. But how we can help to deal with this problem? And welcome, here we go. Well, in global health issues and strengthening nation capacity of achieve equality today, will be presented by our guest lecturer, Mr. Professor Kai Telly. Welcome, Mr. Professor. And our moderators today is Ms. Junior Wardani, PhD. Well, and the event will be opened with a speech by Ms. Sulistiawati, PhD. For Ms. Sulistiawati, PhD, please come into the stage.
Good afternoon. Assalamualaikum warahmatullahi wabarakatuh. My name is Sulistiawati, so I'm the representative from Master of Public Health Study Program. Today, as the organizer, would like to welcome to you all to our guest lecture today, entitled Global Health Issue and Strengthening National Capacity to Achieve Equity. Firstly, let's thank to Allah Subhanahu wa Ta'ala who gathered us on this occasion because we could not have gathered and held this lecture event without His blessing and His mercy. I'd also like to thank to the committee that helped us during the preparation and organize this event. We also thank to Prof. Dahlan our speaker today. Thanks for your time and welcome to our museum here, Museum Muhammadiyah, Universitas Ahmad Dahlan. Dear our students and all participants in online meeting, thank you for joining us today. This event target undergraduate and also postgraduate in Ahmad Dahlan University Public Health Faculty, actually to provide insight into global health and also health system in general, because this is important to public health practitioner and also student, that they have to know in which sector they can contribute and also what programs should be prioritized. Today we receive outstanding enthusiasm from the student. More than 300 students registered with us to join, which facilitated in hybrid, online and offline. We are happy about this, that indicate this topic is interesting and for everyone. Finally, as the organizer, we apologize if there is any limitation during the preparation on organizing this event. Hopefully, it will be beneficial for us, and also please enjoy the guest lecture. That's all from me, and wassalamualaikum warahmatullahi wabarakatuh.
So thank you so much for Ms. Sulistiawati. It's an honor for me. And well, to shorten the time, I will turn today our sessions over to our moderator. She's a lecturer in Faculty of Public Health, University of Ahmad Dahlan, Yogyakarta. Over 25 years expertise in developing and implementing public health programs, collaborating with local communities and healthcare professionals to address social determinants of health, and also skill in research and data analysis, student support, and community services management. And she's completed the study Master of Public Health at Gajah Mada University, Yogyakarta, Indonesia in 2012. Population's health statistic and maternal child health issues, and the doctor of philosophy public health, Taipei Medical University of Taiwan in 2020. Maternal child health and community services issues. Without further ado, Ms. Yunia Wadani, PhD. The time is yours.
Okay, thank you for Master Ceremony. Hello everyone. Hello, how are you today? Good, okay. Are you ready to join in this guest lecture? Yeah, okay. Before we start for the guest lecture, we will make a yell first, okay? Okay, if I say about the global health issue, put your hand here. It's like salam sehat untuk Indonesia. Yeah, global health issue, yes. Yeah, if I say strengthening national capacity to achieve equity, you say ready. Yeah, and last, if I say FKM UAD, Jaya, Jaya, Jaya. Okay, okay, ready to try? The first one, global health issue. Yes. Strengthening national capacity to achieve equity. Ready. FKM UAD. Jaya, Jaya, Jaya. Thank you. Global health issues are currently one of the main challenges faced by countries in the world. Infectious diseases such as HIV, AIDS, malaria, and tuberculosis, and also non-communicable diseases such as diabetes, cancer, and cardiovascular diseases are increasing in almost every country. In addition, the COVID-19 pandemic has highlighted vulnerability in global health system and disparities in access to quality health services. The important thing of strong national capacity is addressing health issue cannot be overstated. Increasing national capacity such as developing medical personnel, strengthening surveillance system, and supporting research and development is an essential to achieving health equity and balance. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, everyone. Good afternoon. I hope you will enjoy with the guest lecture, because we know that we often have lunch, and sometime after we did it, we will feel sleepy and want to sleep. I hope you enjoy and stay to listen and learn about the topic. Okay. I hope you will doing well today. Welcome to our guest lecture session. My name is Junior. I will be a moderator in this afternoon. We are fortunate to have our esteemed lecturer, Prof. Guide daily with us to guide and deliver and also give important issue in our health. Let's make this productive in interactive session. Agree? You should make this session with the productive and interactive session. No sleepy, no chit chat, no make send or receive. We are. Okay? Agree? Agree. Okay. No speak too long to kick off our session. It's great pleasure for me to introduce our speaker today, who is going to talk to us about the global health issues and strengthening national capacity to achieve equity, which I'm sure will provide us with some interesting issue and also for some interesting insight. Our speaker today is a hardworking, values-driven, research-oriented individual with a track record of the delivery. Professor Guide Daly is an extremely experienced senior leader and manager of higher education. He was the provost and senior vice president of the British University in Egypt. Jadi jangan kalah kalau beliau bisa bahasa Arab ya. Where he was responsible for the overall strategic development and operational delivery of academic provision. Prior to joining to British University, he was the Deputy Vice Chancellor at Coventry University, where he was a lead for teaching and learning and student experience across the Coventry University group. In addition, he was Associate Dean of the Faculty of Health and Life Sciences at Coventry University for over 6 years. Prior to that, he was head to the School of Health and Social Sciences at University of Gloucester, right, Prof? Gloucester? Oh, Gloucester for 6 years. It's too difficult to speak. The other hand, he has been a member of various national yogi and local group and bodies related to the National Health Service, and he also as a non-executive director and committee member of the Health Services, Education and Social Housing. He is an experienced social policy academic, and he has produced 4 books and more than 100 papers and research reports. Okay. By the way, in fact, I don't have enough time to read our speaker CV. It's too long. It's too many information and too many like interesting completely because his CV is yes. I don't know how to speak. Luar biasa in bahasa. And the presentation must be carried out immediately. So, well, I would like to invite our speaker, Professor Gay Deli, and please give a warm welcome to him. Professor Gay Deli, the floor is yours.
Okay. Let us see. How do we find the presentation? Is it next slide, maybe? No? Let's see. Is it on the... Let's see. Sure. Oh, there we are. Okay. Yeah, there it is.
Oh.
And maybe...
We try to check first. Oh. Enggak, ininya kok enggak jalan ini. Tadi itu jalan. Itu. Yes, Ma'am. Udah. Tadi itu jalan. You already tried it.
It worked. It worked. No? Where do we point it? We pointed at the computer.
Already checked in this pointer is run, but I don't know.
Okay. The same thing happened yesterday, so we're used to it now. Well, I need it. I need the pointer because I'm going to go back and forward like yesterday. And back as well. So I'll go back and forward. Okay. Okay. Okay, we'll make a start. If we can go back to the beginning, please, of the slides.
Operator, bisa dengar saya? Dari operator bisa dengar saya? Ya, dengar? Halo, Umi? Ya, oke. Okay, the first slide. Okay. The first slide. Yeah, okay. The assistant will assist you for the presentation.
Okay, thank you. Okay, so I was asked to talk about global health issues and how we strengthen the national capacity to achieve equity. So I'm going to try and do that in a number of ways. Next slide, please.
Next slide. Lanjut. Slide berikutnya. Operator, halo. Pak Samsung nggak connect. The next slide. Nggak harus.
Yeah, okay, I can do that. Can we have the next slide, please? Okay, so as we said in the introduction, my academic background is social policy and health policy. I have written a few books and a number of articles on that. And also what I've been doing over the last few years has included visiting your fine country and helping advise in the establishment of your universal health system, which is an absolute fantastic achievement. I think we were saying yesterday, probably it has taken about 10 years to get nearly 100% coverage of the country and also having fantastic satisfaction levels as well. Next slide, please. So what I'm going to try to do this afternoon is just explore some of the health issues and disease burden in the world. I'll refer both to the UK and a little bit to Indonesia and more widely. Another thing to think about is what we understand by equity as opposed to equality. And I'll then do a little bit about explaining health inequalities, which is different from healthcare inequalities, and how one might go about combating those health inequalities. Thank you. Next slide, please. So, I want you to think about maybe these 4 questions. We had in the introduction a little bit about some of the major diseases or illnesses in Indonesia and globally. And what's the underlying causes of those? What's the difference between equality and equity, and what are the major ways of combating poor health, morbidity, and indeed early death, mortality? So I don't know whether or not, just have a think to yourself and maybe talk to the person next to you, or if you're online, scribble down what do you think maybe the major diseases, the major causes of illness are at the moment in Indonesia and across the world, and what the underlying causes are of that. I'm going to give you about 30 seconds and then I'd like some people to be brave enough to give us their thoughts. So let's do that in a few seconds. We need to go back to the slide, please. Forward, sorry, forward. That one, yes, thank you. Yeah. Okay, anybody got any ideas? Can we have 5 major diseases that Indonesia faces and the world faces? Any thoughts? You had a clue from the introductory speaker who was telling us some of them. Any thoughts? What do you think in Indonesia is the biggest cause of illness or death? Cancer? Cancer, probably one, yeah? Heart. Diabetes, cardiovascular diseases, coronary heart disease, certainly. Any others? Hypertension, probably, yeah. Good. And what do you think some of the underlying reasons are for that? Why is it that probably in Indonesia you've got higher levels of maybe of diabetes and maybe of coronary heart disease than we have in the UK? What do you think are the reasons? Lifestyle, people were saying? It's partly lifestyle, yeah. Yeah, absolutely, yes. So government policies will make a difference. Some countries, for example, there are massive numbers of people who die from road traffic accidents. That's to do with the infrastructure. That's to do with what governments choose to allow and not allow, to invest in and not invest in. So yeah. So we'll explore some of these underlying reasons, because if you're individualistic, if you think of the world simply in terms of it's about what individuals choose to do, as opposed to somebody who is more community orientated, then you will probably think a lot of this is to do with individuals and their lifestyles or their genetics, and really it is their fault when they get ill and their fault if they die early. Other people, public health perspective, epidemiologists, and others, some people from a political disposition will say, no, it's not, certainly not solely about the individual, nor indeed is it necessarily solely about what healthcare systems you have. It is also to do with the wider environment that one is living in. So think of something like the impact of the climate crisis now, and people who are living with the consequences. You know, they're being flooded, they've got drought, their communities are devastated. That's not their fault. That is perhaps the fault of governments and affluent societies, but it's certainly not the fault of the people who are on the receiving end of it. Okay, so we'll look at some of this. Can we have the next slide, please? So what we'll cover, hopefully, is a little bit about the global health issues and disease burden, a little bit about equity and equality, a little bit about explaining health inequalities, certainly from a UK perspective, where since about 1980 we have recognised the fact that there are health inequalities and how to explain and understand them, and also how to tackle them, so how we combat health inequalities. Okay, so we're going to try and do that, and probably over maybe half an hour or so, if the technology allows and everything else. So let's have the next slide, please. Okay. So we've explored a little bit about that, some of the major diseases, major causes. We'll come on to equality and equity and the ways of combating poor health in due course. Okay, next slide, please. Okay, so many people would say the major diseases and illnesses and their underlying causes, well, we talked about diabetes, we talked about cardiovascular disease, you were talking about COVID and respiratory diseases. Obesity is certainly a disease of affluent societies, and it's interesting to see as Indonesia continues to develop whether or not you too will have those challenges. Certainly, it's a big challenge in the UK and in the US. You just have to watch. So I sometimes, because I've got nothing else to do, I will watch golf on the television. And I look not just at the people playing the golf in the US Masters, you look at the spectators. And probably over the last 20 years, those spectators have got bigger than they used to. Similarly, in the UK, people are getting bigger. More generally, it is a real challenge, a real problem. And also, I was surprised when I'm working in Cairo. Again, it is an issue. Now, so obesity. I suppose another one, particularly amongst young people, that is being recognised is mental illness, and I think we've seen that. We saw it as the impact of COVID in the UK and elsewhere. I think we see it amongst young people, Gen Z and what have you, in part also because of the impact of social media and the fact that you are always telling each other what a wonderful time you're having. When you take pictures of these foods, you take pictures of yourself in front of a temple or in front of a football stadium, and you're going, look at me, I'm having a wonderful time. And all your friends are going, oh, I'm not having a wonderful time, I'm not as good as you, and all that sort of stuff. Or, pictures of how beautiful or handsome you look. And other people, getting stressed by all of that. So certainly there has been an increase in reported mental ill health recently. So what's the underlying causes of some of these? Inequality and insecurity, the climate crisis, poverty, migration. Homelessness are one certainly we experience as being underlying causes in the UK. Next slide, please. So next slide. Oh, no. Next. Going the wrong way. Okay, thank you. So. One analysis said in terms of the global burden of diseases, as far as the West Midlands in the UK where I live, lots of them were to do with physical problems, low back pain, ischemic heart disease, cardiovascular disease, cerebrovascular disease, COPD, bronchitis, lung cancer, and Alzheimer's and other dementias. Next slide, please. Another one said that the 10 most common health issues were problems of physical activity and nutrition, and obesity, tobacco use, substance use, HIV/AIDS, mental health, injury and violence, the quality of the environment, lack of immunizations, and also access to healthcare. Often we think about healthcare when, in actual fact, its impact is not as significant as some of the others. Next slide, please. So what we had recently in the UK was we've had a new government under the Labour government under Sir Keir Starmer. He and the Secretary of State for Health, West Streeting, asked somebody called Lord Darcy, who is a consultant surgeon and an eminent professor, to look at the problems, the challenges of the health system and health in the UK. And his report of this year said that the prevalence of these particular health conditions in England are the main challenges. So anxiety, mental health we've talked about, musculoskeletal disease, high blood pressure you mentioned, depression, diabetes you mentioned, asthma, coronary heart disease, coronary obstructive pulmonary disease, and heart failure as being the main ones. Next slide, please. And then another survey worldwide. What adults were saying were the issues that were biggest health problems facing them in their country. And this was in 2004, again similar. Mental health, cancer you mentioned, stress, obesity, drug abuse, diabetes, heart disease, alcohol abuse, smoking, COVID itself, and dementia. Next slide, please. This one was a survey of people conducted by the polling group Ipsos. And the question was, thinking generally, which of the following, if any, do you see as the biggest health problems facing people in your country today? And so over the last 6 years or so, you'll see the rise in mental health as being an issue, cancer remaining near the top, stress, obesity, drug abuse, and obviously coronavirus initially, but that's decreased over the last couple of years. Next slide, please. So, in terms of the burden of disease in the UK and the developed world, the overwhelming burden is from non-communicable diseases, COVID being the exception, as it were. And these were the biggest killers and the main causes of morbidity down there as well. Next slide, please. In the developing world, one is seeing mortality improving. That's to say people are living longer. But just because people live longer doesn't necessarily mean they're healthier for it. We'll come on to a slide about that in a moment or two. Infant mortality is also improving, as are healthcare systems, and particularly social insurance-based health systems. So one is seeing sometimes the population pyramid changing shape. So if you think of it, traditionally, and in less developed countries probably still the case, the population pyramid is a triangle, whereby at the base is lots and lots of young people. And then as you go through the ages and up the triangle, you will get fewer people, you will get more people who have died. Such that therefore, at the top of the period, when you have people as old as me, or even older, they do exist, then very few people. What one is seeing is two things. One is seeing fewer people being born. Indonesia is probably an exception to that, in some ways, still a young population. But if you look at somewhere like China, for example, not just because of the one-child family policy, but also otherwise people choosing not to have lots and lots of children, and people living longer. The triangle is changed shape, probably more like a square in terms of different proportions of different age groups. And in some countries, the triangle is even being inverted, whereby there are more old people and fewer young people. And that's increasingly becoming the case in the UK and Europe and the US as well. So I give one example. My parents, they had 8 children. I had 7 brothers and sisters. That was unusual then. It would be very, very unusual now. We have 3 children, my wife and I. That's quite unusual. The number of children per families in the UK now is the lowest it's ever been. It's at less than 2, 1.8, 1.6. And surveys have been done. Why are young people choosing not to have children and everything? And it's because of the anxieties about the state of the world and what have you often, and affordability as well. So the population shape is changing. Still the traditional diseases, the communicable diseases are still prevalent in the developing world to a greater extent. But changing disease patterns to those of more affluent societies. So in Indonesia, as an example, I'm sure you're moving away from the communicable diseases to the diseases of affluence, as it were. As we've said, obesity, cardiovascular disease, diabetes, mental health, mental illness probably as well. Next slide, please. I said we'd talk a little bit about equality and equity. So when we're talking about combating health inequalities, one of the things we need to think about is what do we mean by this? And equality is often regarded as treating everybody the same. So you see that box on the left-hand end of the picture. So there, that's society. Everybody gets the same, as it were. In the second image, individuals are given different support depending upon their needs. So that's more equal access, more equitable. In the third image, all three people can see the game because all the barriers are taken away and what have you. But so this difference between equality and equity, maybe I'll give you another example. I used to, when my father was alive, I used to have lots of arguments with him. We remained friends, but we'd have lots of political discussions and what have you, as you may well yourselves. My father was a GP, a general practitioner, a family doctor, and we'd talk about equality and equity, and he said, I don't discriminate, I treat everybody the same. Any patient who comes in to see me, I treat them exactly the same. So he thought that, by treating everybody exactly the same, treating everybody equally was fair. What we've now moved on to, I think, is a notion that actually you do have to treat people differently from each other in order for it to be fair. So you treat men differently from women. You treat children differently from adults. You maybe will spend more time with a particular demographic group in terms of particular diseases because it's more prevalent there than you do for others. So a notion that we just treat everybody exactly the same it's a bit old thinking, I think, is probably what I'd say. Next slide, please. So health inequalities, according to the National Institute of Clinical Excellence in the UK, regarded as differences between people or groups due to social, geographical, biological, or other factors. These differences have a huge impact because they result in people who are worst off experiencing poorer health and shorter lives. And I'm going to give some examples of these now. Next slide. So, as I said, in the UK, we've had a focus on health inequalities, even though they are persistent for a long time. So in the 1980s, we had the Douglas Black report on inequalities. We then had another report in the 1990s. We had a second report in the 1990s. And even now in the 2000s, we're still trying to deal with health inequalities. And I'll just use an example if we go to the next slide. So where I used to work, if we go to the next slide, you had differences in the ages at which people would be expected to live and therefore die, not dependent upon where they lived, but where they lived meant that you had people who had greater longevity, tends to be in the nicer parts of the city, whereas the poorer parts of the city, people died at a younger age, for both men and women. Women tend to live longer than men, though women also experience greater morbidity, prevalence of illness, than men often. But just in the city of Coventry, where I used to work, you would have a difference of 8 to 10 years between individuals and communities. Next slide, please. And indeed, the King's Fund, a health policy think tank in the UK, said very recently, last year or so, healthy life expectancy is more than 18 years lower for the most deprived compared to the most affluent. So if you can think of that, and it's the same for men and women. So men, on average, will live into their 80s if they are affluent, and will live 18 years less than that if they are younger. And this is on deciles. So these inequalities persist. Next slide, please. So why do they persist? Next slide. Dahlgren, one of the studies of health inequalities I mentioned a moment or two ago, with Margaret Whitehead, they came up with this model, which is often used, and they said, we often think it's to do with individuals in terms of their biology, their genealogy, their physiology, or their lifestyle. But they said it's also about one's community. It's also particularly about the general socio-economic, cultural and environmental conditions in which one lives. So one's housing. Yes, one has healthcare services and the extent to which one can access them. Water and sanitation. Unemployment or employment and the types of work that you do. So the living and working conditions. The work environment. One's education. And one's the environment in terms of how food is produced and made available. I mean, there's an interesting certificate in terms of education in the UK, certainly, and maybe you'll be pleased to know it may be the same in Indonesia. People who go to university, graduates, they live longer than people who don't go to university, partly because of the jobs they do, partly because of their economic circumstances, the levels of the salaries they earn, partly to do with the environments in which they live. Next slide, please. So we often talk about social determinants of health. The World Health Organization does, other organizations do. And so similar to that Dahlgren model, it's a mixture really. So, it's what makes us well, what makes us ill, what allows us to live a long life, makes us live a shorter life, is often to do with the social determinants, which are there. Education, I was mentioned, economic stability, one's community, one's neighborhood, as well as access to health care services. But often, initially, people think it's all about access to healthcare services. That makes the biggest difference. That's not the case. Next slide, please. Because it has been argued, some people say it's not quite these figures, but it's been argued that the socio-economic factors have a 40% impact on you. Your physical environment, 10%, your health behaviors, 30%, access to good health care, up to 20%. Some people say it's only 10%. So if you think about it, how we're going to deal with the global burden of disease, it's not just about universal health coverage, it's not just about immunization, It's not just about telling people to live healthier and stop smoking and do more exercise and what have you. It's also about particularly the socio-economic factors and also the physical environment. That's a good half of it, as it were. And the education, job status, income, community safety, family and social support, all of those things impacting on one's health status. Next slide, please. And in some ways, this is not, I suppose, a surprise, because if you go back into history and the reasons why health has improved in populations, then a lot of it was to do, particularly early on in industrial societies, with the environment, as this graph illustrates. So, things like clean water and what have you. Later on, drugs, medicines did have an impact. Next slide, please. But also what we want to be thinking, therefore, is not just about how long you live, but having healthy lives. And so we had a government minister in the 1990s who talked about adding life to years as well as years to life. And in that regard, ill health we talked about, and how to improve them are listed there. And then I'll move to the next slide, please, if we can. So the idea being that you add years to life and also life to years, and we talk about compressing morbidity and postponing mortality. So therefore, model A, you can say that's where we are today. You get to a situation and maybe by 50, you're starting to get illnesses and you're starting to be less healthy. You're starting to need more assistance and more medical interventions. And then maybe within 15 years or so, you die. But you've got a period of 15, 18 years or more where you're not very well. Model B, you could argue, is slightly better in that people live longer. But if people are simply living longer, but they're ill, you've not achieved too much. What you want to do is to try to postpone it when people become ill to when they're, 70 or 75. And that will allow them, yes, to live longer, but to have a shorter period of when they're ill. So certainly my ambition is personally to, and I'll probably get ill tomorrow or get hit by a motorcyclist in Yogyakarta or something like that. But my ambition is to remain as healthy as I can be, certainly till I'm 75, carry on cycling, carry on trying to play football. I might even get better. I'll slow down a bit and I'll stop, some of those things maybe when I'm 75, and then, maybe, have a few years that are quieter than that, as it were. But the notion, my dad thought that, when he was 60, he had to stop doing everything almost, he shouldn't remain physically active. The science and all of that and the thinking on that is more of this rather than less of it. Go to the gym and all that sort of thing. Next slide, please. So, but certainly in the UK at the moment, and again this is taken from Darcy, change in methodology, but the healthy life expectancy. So how long you remain healthy for, and at what age do you stop being healthy, and you get these morbidities. It's not improved, and as I said, by the age of 60, 62, in men and women, vast majority of UK, on average rather, in UK, people are becoming having to deal with the morbidity, with illnesses and what have you. Next slide, please. So in the developed world, therefore, yes, people are living longer, or certainly were. We'll see a little bit of retraction there. Yes, we've had better infant mortality. Yes, we've got developed healthcare systems, but healthcare doesn't equal health, as we've seen. You know, it has a 20% impact. Population pyramid is different from developing countries. It's a square or horizontal, and the diseases of the developed worlds are those as we've seen. Next slide, please. In the developing world, again, mortality is improving, including infant mortality. Yes, countries are developing their healthcare systems, including Indonesia, and such health systems are more effective. Population pyramid is changing shape. Traditional diseases, the communicable diseases, are becoming less, and you're seeing the prevalence of diseases seen in the developed world as well. So there's changing disease patterns, and there are changing expectations as well around family and responsibilities. I'm conscious of the time, so I'm going to whiz through some of these other slides. Okay, next slide. So I was going to talk particularly about Indonesia and its older population, but I'm going to jump on. So next slide, please. And next slide. Next slide. Okay, so let's look at how one strengthens the capacity to achieve equity, how we make improvements to people's health as communities as well as individuals. What to do. Next slide, please. So the answer is, in many respects, is what we've seen before. You concentrate on all aspects, but probably particularly in terms of those aspects that are coloured green, as it were, the socio-economic, cultural, environmental conditions. Next slide, please. Because, as we've said, you know, it's not just about healthcare. It is partly about health behaviours, so changing health behaviours is good, but it's also about changing the physical environment, and particularly changing people's socio-economic factors. Next slide, please. So if we want to have an impact, where would we intervene? The biggest impact will be in those wider determinants, those socio-economic, environmental situations. Probably secondly, mental health, then maybe lifestyle, and then for a small proportion of activity, we would concentrate on illness. Most health systems probably are an inversion of that, and the focus is all on illness and lifestyle, whereas the biggest impact you would get from the wider determinants and maybe focusing on people's mental health as well. Next slide, please. So, in conclusion, if we want to combat the global burdens, if we want to improve equity, you don't just talk about healthcare and universal health coverage, even though they're important. You have to focus on the socio-economic as well. So you have to have political will to do that, because you are challenging entrenched privilege, really, because you're having to redistribute wealth within a country and also between countries. And as we've seen with the environmental conferences, the COP 27, 28, 29, that's very difficult to do. Change one's physical environment, change one's health behaviours, as well as healthcare. But it's the socio-economic and the physical that are the big ones to focus on. Next slide. So that is it. I hope that's been helpful. Thank you very much. Terima kasih. Happy to answer any questions as long as they're not too difficult. Thank you.
Okay. Thank you so much for Professor Gergely that you share all the experience that you did before. Okay. We will start to question, and now we will open the floor to question. But I give a comment. We will divide this session into two terms. The first one is for the offline participant, I mean all the audience here. And the second, we will open the question for the online participant, even though we already received two questions from the online participant. Okay. I encourage everyone to ask a question or make comment, but you should state your name and also give the question clearly. Okay, for the first term, okay, silakan. State your name and make question clearly.
Well, Assalamualaikum warahmatullahi wabarakatuh. Thank you so much for moderator. And hello, Mr. Professor. How are you today? Hope you good? When we're talking about global health issues, of the various diseases that kill many people, one of the diseases is related to a policy in a country. Let's look at the amount of sugar in a product. We know it's harmful, right? But how can it continue to be produced? Is the authority of the government in a country inferior to the owners of company, or are there other interesting there? What do you think this had? And we know about this. This has been going on for a long time until now, I think, and I guess this will have an effect on health equality. But what do you think about it? And can you give me some tips to fix these problems, or maybe something like that? Thank you so much.
Okay, thank you, Yoga, for your question. Could you please address it?
Thank you very much. Can you hear me okay? Yeah, it's working. I think it's a really interesting question. It's a question that should be addressed here and back in the UK certainly, because sugar in products it has all sorts of detrimental effects on people. So where do we start? The sugar producers, the producers of unhealthy food are very powerful. Very difficult for governments to, governments are often scared to challenge them and tackle them. Some governments, some political parties will get funding from these industries, these companies, to help them in their election campaigns and to get re-elected and all that sort of stuff. So they're going to be reluctant to challenge them. We did have in the UK. We have had some attempts at sugar taxes. So therefore, goods that are got lots of sugar in them, there is an extra tax put on them to make them more expensive, so that people will be less likely to consume them to the same extent. Similar sort of approach and philosophy to taxing cigarettes, which we've done in the UK, and is accepted. I think there's a couple of other things. One is that it's only quite recently, I think, that we've seen the damage, the evil of sugar, as it were. It used to be fats that we would all say were bad. The science has changed, and the science will continue to change. Science does change, and I think we continue to have a better understanding of things. So there's a bit of that. But also, certainly in the UK, I don't know about Indonesia, what I was talking about at the very beginning, whether or not you are an individualistic society, where you say individuals should be allowed to make their own choices, and we shouldn't have governments interfering in their lives. Therefore, we should, government shouldn't be taxing the foods that I eat. It's my choice, and I will live with the consequence. Others would argue against that and say, for various reasons, no, we've got to think about the wider community. We've got to also maybe help people to make the healthy choices that they wouldn't otherwise make. We've seen that with how to reduce smoking levels, alcohol levels, but also, I remember, because I am of a certain age, as it were, I remember we had debates in the UK about whether or not people should wear motorcycle helmets, whether people should wear seatbelts, and people would say, it's my choice. The government should interfere with me if I want to go motorcycling without a helmet, if I want to drive my car without a seatbelt, I should be allowed to. Mostly, we now think that governments do have a responsibility in regard to those two things. Tell people you've got to wear a crash helmet, you've got to wear a seatbelt. So there's that potential, as it were. But I think personally, yes, there is a place for government to help people make the right decisions. There's a place for government in taxing things that are bad for you and maybe subsidizing things which are good for you.
Okay, I took this as clear answer, okay? Okay. Anyone else? Okay. Nilo. Right, Nilo, yeah. Okay. Don't forget to state your name.
Okay, thank you, Ms. Union and then Professor. My name is Dewi. I'm a little bit curious about the community support, especially in the UK. Maybe my question, how can local communities contribute to improving public health outcomes in UK? Thank you.
I think there's a number of ways. First of all, we have talked about empowering communities. Instead of thinking we will do things to communities, we work with communities and individuals because they have the abilities, the wherewithal to help to shape and make their lives better, as it were. Often those communities will know better than the experts what the problems are in their communities and what needs to be done, particularly over things like, I don't know, the environment and what have you, instead of having experts coming in and giving them the magic solutions, as it were. So I think it's in part that.
Jelas? Okay. That is different, very different with Indonesian style. Okay. Does anyone else have a question or make a comment? Okay.
Okay, thank you for the time, Prof. K. Daily. Okay, today I want to ask, in UK, how can we promote health equity and reduce health inequalities? Because we are from health promotion, so I think we must know about it, and we can use in Indonesia maybe. Okay, thank you. How can we promote health equity and reduce health inequalities?
Okay, if I understand your question correctly, about how do we promote good health? We have what should I say? We have the discipline of public health, as we have public health experts in our local authorities, we have directors of public health who have a responsibility. We have, as part of those local governments, regional governments, often these days what they will talk about is ensuring that any decision is made, the health consequences are often considered. But health, public health professionals, they are a discipline similar to other aspects of medicine and such things. There is a college of public health and what have you, and they have a perspective in terms of how one deals with health problems, prevention, promotion, and interceding, really, as being the three components therein. So I think that's probably what I would say on how we do that. I think particularly the promotion of good health, of good healthy behaviours, the promotion of immunisation programs are very important as well. We've had in the UK a backlash against that by some people. You saw in COVID, people, all these sort of scare stories of you're injecting me with I don't know, poison and all that sort of stuff, so people wouldn't take it. Same with mumps and measles and rubella. We've had people saying, I'm not going to let my children have them, and therefore we've had increases in incidence of measles. So there's a really important public health message there as well, I think. And general public health education, going into schools and helping educate people.
Okay, collaboration is. Okay, thank you.
Okay, clear, is that clear? Iya, jadi intinya bagaimana kita mengolah ataupun membuat promosi itu sesederhana mungkin berdasarkan apa yang ada di sekitar kita. Cara-cara sederhana, hidup sehat dan lain sebagainya.
And just on your point about collaboration, absolutely. We have a saying in the UK, health is everybody's business. We also had a situation whereby there was a campaign in the National Health Service called Every Contact Counts, which was where every time a member of the public had a contact with a health professional, they didn't just talk about the poor eyesight, the bad ears, or whatever. They also talked about their public health. So I remember I talked about playing football. I got a football injury. I went to the eye hospital, and they were talking to me about that. But then they also talked to me about my general health and advised me how I could live more healthily. So health is everybody's business, and every time a health professional is talking to a member of the public, don't just talk about the appendix, the diabetes, but talk generally.
Okay, thank you. We have several time for a few question more. We give for the participant on the side, on the sheet, on the left side maybe. Ada yang bertanya di sebelah kiri. Kalau nggak bisa berbahasa Inggris, I will translate for you. Ada? Tidak ada? Okay. Does anyone have any question before we start to give the time for the online participant? No? Okay. Oh. Yeah, online participant. Okay. Okay, the time for you.
Perkenalkan, I'm sorry, pakai bahasa ya, I'm so sorry.
Okay.
Takut salah ngomong nanti. Saya Atika Ayu dari MKM Peminatan MRS Manajemen Rumah Sakit. Mohon bantuannya Ibu untuk ditranslitkan terkait dengan global health issue ini. Ini kan public health ya, kesehatan masyarakat. Kalau dengan manajemen rumah sakit yang alias itu peminatan saya sendiri, itu kaitannya di mana? Kalau dengan saya yang ada di rumah sakit itu.
What sort of relationship between global health, public health, and hospital management?
Yes.
Yeah. Okay. Well, I think, as I was trying to say in the presentation, hospitals, management of health is only a small part of improving global health, improving people's health. We sometimes talk about the National Health Service as being a national illness service. Hospitals, often, they deal with illness. They don't deal with health. And therefore, if you want to improve people's health, it's about the wider society and all aspects of that. That's what you've got to focus on. So you have to focus on climate and the climate crisis, improving it, people's housing, people's education, people's income, people's diet and lifestyle. That's where you will get the biggest impact in terms of improving the health of the world's population, rather than having, the best, shiniest, most technical hospitals in the world.
Okay. Clear? Is it clear?
Okay.
Ladies and gentlemen, we have a 15 minutes left, and I will start to give the question or receive question from the online participant that they sent to me. Good afternoon, Professor Gaideli and distinguished audience. My name is Andriano Siemens, a postgraduate student from Timor-Leste. Timor-Leste is different. Okay. Timor-Leste. Currently pursue a master degree in public health at University Ahmad. First, I would like to apologize for not being able to attend in this event, and then I'm grateful for the opportunity to follow this session through YouTube live. So it's too much sentence, but I will start for the topic discusses provide valuable perspective, but also provoke critical reflection and challenging question regarding the implementation of this concept across the different nations. Allow me to pose two questions that might be difficult to answer, but are essential for us to ponder together. The first one, in the context of global health, how can countries with limited capacity address the dominance of developed nation in setting global priorities that may not align with their local needs without losing international support? And the second one, while equity is an ideal goal, how can we ensure that health policies designed to promote equity do not inadvertently create new form or inequity in other segments of the population? I hope this question will enrich our discussion today.
I will try. I think maybe the second question. Second question was, I think, saying by focusing on health equity, how do you make sure that you don't create, inequities elsewhere? Is that the question? It's okay. Yeah. So the second question is about in trying to ensure health equity. we don't inadvertently create new forms of equity in other segments of the population. But I don't think you will. I think if you improve health equity, then the way to improve health equity is by improving equity more generally. You know, because for me, and I think most people would accept that the biggest cause of health inequity or health inequality is the wider socioeconomic environmental space. In some ways you have to tackle those. I think the answer really is to tackle the wider inequity, and through that you will tackle health inequity. So therefore, in tackling the health inequity, so I think that's what I would say about first. The second question. First question. Yeah, I think it's always a challenge. I think, thank goodness, in some ways we have the World Health Organization, we have the United Nations with its development goals, which are, as I say, which are helpful. I think developing countries, less influential countries, often must try and work together so that they together have greater influence, and they must campaign against some of the inequities that transnational corporations, other nations, global finance impose upon them. So I think that's what I would say really on that.
Okay, thank you so much. Does anyone ask by online meeting? Is there enough? Okay. Okay, we have 5 minutes left. Anyone ask in offline participant? No? No? Okay. We only have 5 minutes in. Okay, as we conduct today's session, I want to express my sincere gratitude to speaker for your hard work and dedication. You has contributed to a deeper understanding of the subject discussed, and we appreciate the knowledge you have shared with us. I would also like to thank you for the participant, not only in offline participant, but also the online participant. We have 100 participant. Okay, berapa? Oh, 100. The MC say 100, but actually we have around 300 participants in online. And thank for the audience for your attention, engagement, and the stimulating question that gave in the discussion. Let us carry forward the insight gained here into our future and future studies and endeavors. Once again, thank you all for being here today, and I wish you continued success in all academic process, because almost all the participant is student, not only for bachelor but also for the postgraduate participant. I'm Yuniar, as your moderator today. I apologize if I have mistake when I lead the meeting and guest lecture. Have a wonderful day. Makan pisang bersama roti. Tetap Prof Kai Deli selalu di hati. Okay. We close this meeting with reciting hamdalah together. Alhamdulillahirabbil alamin. Nasru minallah wa fathun qarib wa basyiril mu'minin. Wassalamualaikum warahmatullahi wabarakatuh. time to yours for MC.
Thank you so much. But for the first, we give applause, a big applause for our guest lecturer today. And it was a great presentation, even question and good answer for Mr. Professor. And well, next is awarding certificate for the Master of Public Health to Mr. Professor Gaideli and our moderator, Junior Wardani, PhD. And we're invite to our heads faculty programs, Miss Rosidah, PhD. Please come in with me in our stage here. And to our head study program, Miss Professor Siti Nurjana. Please come up here with me. Forget for everybody, we're gonna take a picture together for during an online and offline, of course. So don't go anywhere before it's ended. Well, thank you so much. Well, everybody, that's all for today. Thank you so much for Mr. Professor Gaideli, very useful, and thanks to our moderators, Mrs. Junior, and to the participants who are here today in online, YouTube, and Zoom, or in this room today. I hope the knowledge that can be realized and we can use for our communities in Indonesia. And don't forget to fill in your attendance and certificates, and we will do a group photo sessions. For everyone, please come here in our stage. We're gonna do photos together. Well, everyone get ready. Everyone in positions, right? Okay. Yeah, I'm here. Oke. Habis ini kita oke. Okay, let's do videos. Remember global health issues. Okay. Strengthening national capacity of. Yeah. Okay, let's do it. In 1, 2, 3, global health issues. Strengthening national capacity to achieve equality. Fakultas Kesehatan Masyarakat. FKM UAD. I'm so sorry. Okay, let's do it again. In 1, 2, global health issues. Strengthening national capacity to achieve equality. FKM UAD. Well, thank you so much for our participants and for our guest lecturer today. Well, thank you so much for our participants today in this room, for our crews and online, and teman-teman bisa scan barcode yang ada di layar. Ini buat presensi dan juga buat sertifikat. Terima kasih.